Okay, so today is a very special session, and with us is a very, I would say, we are privileged to have the guest on the channel, Professor Giacomo Bellani from Trento, Italy. And he is very passionate about mechanical ventilation and the respiratory physiology. So when we were going through this mechanical ventilation courses and all those things, I was very fortunate that he accepted that he can share his insights, his immense insights and wisdom for so many years, which he has given to the students and other healthcare professionals. Not only this, today's session is important and special because after a long wait, his book is going to release next week, coming week, and we will discuss a little bit about that. And just for the audience who is listening, because of the network glitch, there is a slight frame lapse in the video from in the professor's video, but audio is good. I think you all will enjoy and learn a lot from this. So welcome, Dr. Giacomo Bellani, Professor. We are very, very delighted to have you on the ICU channel.
Thank you so much. Thank you so much, Ankur. And please, Giacomo is more than fine.
Thank you. Thank you. So before I start asking some of the questions which we and our audience have in the mind, I know you are very passionate about the mechanical ventilation, and many of the guests who or many of the viewers who are watching this know about you. But if I can ask you to tell a little bit about yourself to our viewers, because if I start, it will take a whole day to explain the things about you. So, Giacomo, if you can introduce a little bit about you to our audience.
Sure, sure. Well, at first, thank you so much, Ankur, for this nice invitation. It's a great honor and privilege being here. And I know you have a very well attended audience, so thank you so much for giving me the opportunity for being here. Yes, I am passionate about mechanical ventilation, and that's something that started back in the roots of my career. I was born and grew up in Milan, and that was almost 50 years ago, I have to say. And then I went into medical school there. I got a great interest into physiology, generally speaking, not so much into respiratory physiology. And then I decided I wanted to do anesthesia and critical care, because in Italy, it's just one specialty, anesthesia, critical care. And so while I was graduating, I was lucky enough to meet my my mentor, Antonio Pesenti, and I've been working in Monza as a resident and then PhD student for many years. And then I was able to get a position there as what you would call assistant professor and then associate professor. And during this period, I had a break in the United States at Massachusetts General Hospital. That was a great opportunity, and then I came back to Italy. And as I said, I did my career there in Monza. And throughout the years, I've always been working as a well, for a few years anesthesiologist, and then mainly critical care physician, always carrying on our research projects in respiratory mechanics, respiratory failure. A big project for me was back in 2013-14, the lung safe study, through the which we published and which we ran thanks to the support of European Society of Intensive Care Medicine, and that was really something very important for me. And as of 3 years, I became chief here in Trento, which is in the northeast of Italy. Probably someone might know about the Dolomite Mountains, which are beautiful mountains in Italy. And so I came here, and I am head of the Department of Anesthesia Critical Care and a professor at the University of Trento. So that's a little bit my professional journey.
I can take a breathe now in between. So, Professor, one thing I would like to ask that much of your work is there in the early days in the Monza, I would say, and also in the Massachusetts General Hospitals. So if we look at you and if we think about you, the first thing which comes in our mind is the respiratory physiology in critical care, which I think you have done a lot of work on that. So what compelled you, or what made you think about, or what made you interested about this, or any case was there which sparked your this lifelong fascination for the lung, I would say?
Yes, thank you for the question, because despite many years passed, I still have like some vivid recalls of that early days. It's a little bit when you, if I can make a comparison, when you fall in love with a person, you very well remind where you met her and so forth. And so, despite it was now more than 25 years ago, I remember that, as I mentioned, I was an intern in physiology, neurophysiology, and then I decided I wanted to still have a like a more clinical internship. So I went to anesthesia, and I remember that respiratory physiology, I didn't like it much when I studied it at the university. I did not quite understand it, and it seemed very complex. And then I remember the days in Monza that I was assigned to a project on CT scan and measurement of end expiratory lung volume. And so I spent a lot of time reading the papers, and at the time it was real papers. You would go in the library, make photocopies and everything. Internet was starting, but most of it was on papers. And I read the papers done by Gattinoni and Pesenti, and Pesenti was there. He was my professor. Those seminars paper on the baby lung, and on the concept that lung mechanics depends on its size. And really, I saw an approach to the diseases that was really based on physiology. And that, as you mentioned, for me was a spark. That was something I really wanted to do in the following years. And and then, as you mentioned, I went to MGH, and that was another type of experience, because a large part of the group was made by engineers. And so I working with them has been really something that has set a given mindset on method, because, as you can imagine, engineers are very methodical. And so I think these two elements together, the fascination for research and the strong method, really in a way shaped my career to follow.
Okay, that's interesting. And now, as we know that after so many years later, then you told that at that time they were real papers, going to the library and taking out those papers and reading. And now internet has evolved to a lot of extent, and now not even internet, we are in the age where there are a lot of quick references, apps, and online protocols are there. So you authored many lectures on respiratory failure and mechanical ventilation, and your book is also coming. So in the era where a lot of online protocols are there, quick references app are there, why you felt it necessary that you should sit down and write a comprehensive text on the lectures which you hold recently on respiratory failure and mechanical ventilation?
Yeah, I I also had a friend of mine who read a little bit of what I wrote, and told me, "Oh, this is very nice, but my friend, books are dead." And so it was not very encouraging. But of course, as you say, we are in a world which is changing, and I see my residents, they always check everything on internet, and I do the same. But still, I think especially in the early year of the careers, the ability of sitting down, concentrate, reading something, and then going back to what you did not understand is an added value. And I have the privilege and the honor to give lectures around, and sometimes I feel like that given that all the material is prepared, the slides and the talk and everything, it was just a little bit of an extra effort, not such a little bit, it was quite some effort, but already the ideas were there. And I like to put it down on papers. It was also a useful exercise for me to put the ideas in a more, let's say, clear and organized structure. And still, I think that the as you said, quick references, protocol, apps, everything is very useful, but understanding and also being challenged, because in the book, as we might touch upon later on, there are some provocative concepts. The idea of challenging your own mind and your own knowledge with these new concepts could be useful, I hope, maybe especially for the more junior colleagues.
So, Giacomo, if I'm not wrong, the book is titled Respiratory Failure and Mechanical Ventilation.
Yes.
So, let me ask this. There are many good books, many books I would say are available on the mechanical ventilation per se. 2, 3 books which we refer frequently. So, why did you felt that this book is a little bit different, or is the approach is a little bit different in this book for mechanical ventilation?
Yeah, no, it's an excellent question, because as you say, there are many excellent books out there, and honestly, I don't think that the book I'm preparing by itself could prepare a clinician. So it's not, let's say, a standalone reference. It's not the Tobin book, just to mention a book that it's an absolute reference in its field. In a way, I think it's a little bit different in that I try to present what is the evidence on a given topic. For example, let's say the definition of ARDS, what is the current status of the definition of ARDS, and then what is my opinion, which is, as it is, my opinion for the good and for the bad, and my interpretation. And I believe that this is a quite useful exercise for the readers to compare what is their own opinion with what is my own opinion, and what is the evidence that we have from the guidelines. The published books, which, as I say, are excellent, do need, however, to be fully comprehensive on a given topic. Okay, in my book, I have decided to speak about some aspects of a given problem, like, for example, PEEP settings. You can write a book on PEEP setting with all the papers, all the. I don't provide an encyclopedic view of the PEEP setting. I provide my own theoretical and practical view on how to do this. And this is the last element, I would say, of novelty. I always try in my talks to put together a little bit, let's say, the more theoretical part, the more general part, but also bring it to the bedside with real, actual clinical examples. Because at the end of the day, that's what it's needed for something to be useful.
So now this is a very interesting fact. Let me take it a little step further. So there are certain protocols, as you said, that there is certain reference books or certain standard protocols which are there in the textbook. And then you are having a patient which has a certain physiology which may be different in that patient. So as an intensivist or those working in the critical care, how do we strike a balance between those standard protocols in the books and the patient physiology which is in front of us? How do we strike a balance?
Yeah, I think it's an excellent question. So the point is, at first, you need the books, and also you need the protocol. Well, maybe you need the books at first to understand how the system works. So first of all, for example, you need to very well understand the equation of motion, how it works, what does it tell you, what are the meanings of resistance, compliance, and so forth. And then you need the let's say the protocols, because they kind of give you a guidance on where you should aim at. For example, lung protective ventilation, we know tidal volume should be 4-8 ml per kilo. All guidelines say that, but between 4 and 8 ml per kilo, there is 100% range of variability. And so how do we decide where to hit? And this is, I believe, where physiology comes into place. So we have to try and stay within a protocol, if this is what we use in our institution, but also we need to be able to understand when we should deviate. For example, I give you another example, PEEP FiO2 tables. I personally don't use them at the bedside. Some people do, and I think there's nothing wrong with that. But you cannot just rely on PEEP FiO2 tables. For example, if you start to increase PEEP and respiratory mechanics worsens, okay, at this point, you need to say, okay, the protocol brought me to here, but then at some point, I will have to take a little bit of a detour from the protocol. So that's the general idea.
So very interesting, because applying the guidelines and the protocols to the patient physiology makes sense. And also, I love this line that we should know when to deviate. This is very, very important, which one should understand, that when to deviate from the guideline. And in this patient, this deviation is technically helping. So when I was getting a glimpse of your book, I think you often mention, not only the book and the lectures, which I heard, that you always say that ventilation or ventilator is not just the treatment, it's a sort of diagnostic tool also. And often the ventilator waveforms can tell you or give you the information which a good CT scan of the chest doesn't give. So can you elaborate a little bit in detail to our listeners? And again, I would say.
No, sure. Yes, I like to say these about mechanical ventilation because, like, well, of course, we think of mechanical ventilation as a therapy, and that's where it started from, right? In the polio pandemics and so forth, to avoid patients from dying, we ventilate them. But on the other hand, we get many information. For example, we can measure airway resistance and understand whether, and compliance, whether the problem is initially restrictive or obstructive. And then we have a measurement of airway resistance, which is increased. And we say, okay, let's try and give steroids to these patients. How do we measure the effectiveness of our treatment? And this is exactly by measuring resistance. So, or in a spontaneously breathing patient, which we cannot separate from the ventilator, we could be wondering whether the problem is the fact that the patient is weak or is overly sedated, the drive is not enough. And by simple maneuvers on the ventilators, which are, by the way, completely free of charge, okay, completely free of charge, and there is no extra cost, we can learn so many things. And of course, sometimes we definitely need to go to the CT scan because it's providing us so many information. But on the other hand, when you are at the bedside and you put the patient prone, you immediately can understand whether you improved or worsened the respiratory mechanics of the patient. And again, this comes for free and it's continuous. So that's why I think that mechanical ventilation is definitely a diagnostic tool.
So means those who are listening, viewers, those who are listening, 2-3 things from this: the ventilator provide diagnostic things which is free of charge, and secondly, most importantly, it's dynamic, it's continuous, it's minute to minute,
Exactly.
providing you what is happening with the patient. So anybody who wants to work on the ventilator or come across the ventilator should master, I think, the ventilator graphics, which is very, very important. They can in real time can see what is happening with the patient lung, which we cannot pick in the CT scan. Now coming to the next question, almost 20-25 years have passed. You started some 25 years back when you just said that. So at that time, roughly it was ARMA trial was there, ARMA paper which came in 2000. So over the period of 25 years or 26 years, how you have seen or witnessed the evolution of what I could say the management of respiratory failure since 2000? Have you seen
Yeah.
any changes?
Oh yeah, definitely. So ALMA trial taught us that lung protective ventilation was important, and then of course there were criticisms because uh, on the fact that the control group of the ARMA trial was not a real control group because tidal volume were too high. But still, I believe that after the ARMA trial, and I was in my very early days, so I barely knew what was happening, but I understood it later on. Anyway, in the, let's say, between 2000 and 2010, we could not deny that lung protective ventilation was important, but lung protective ventilation was basically tidal volume 6 ml per kilo, plateau pressure less than 30. That was the concept of lung protective ventilation. And then shortly after the setting of tidal volume, the focus of both the NIH ARDS network and other investigators moved on PEEP. And I think on PEEP, the situation was a little bit, well, at the end of the day, the situation turned out to be a little bit more blurred than with tidal volumes, because at some point, and I am still convinced on that, but we were convinced that higher PEEP would be beneficial in more severe patients. But then the ART trial somehow uh, uh, cast some doubts on the effectiveness of using higher levels of PEEP. But still, I would say that for PEEP, we've learned much. We still, but we are at the point where we collected pieces and now we have to put them together. And then in 2015, I think it was, the concept of driving pressure came, and that was really a game changer. Okay, that was the greatest change after the ARMA trial publication. So the fact that we somehow finally had a very strong parameter associated with lung injury, that was the greatest change we witnessed in the last 10 years. And that added an important, a crucial element to lung protective ventilation. So that was the, let's say, the next step of lung protective ventilation. And finally, I would say also through COVID, we now use prone position more and more frequently, and that added a further layer, I should say, of lung protection. So that it's my feeling, and I don't have numbers to sustain this, but it's my feeling that after COVID, the number of patients needing ECMO has dropped
Okay.
because most patients are ventilated much more protectively and receive prone position much more often. And so the explosion, let's say, of the use of prone position led, in my opinion, again on to a decrease of the incidence of refractory hypoxemia and need for ECMO.
So, means it was in the early days, it was low tidal volume, which was 6 ml per kg body weight. Then we had plateau pressure. Then we switched to driving pressure, which you were saying, and then now prone position, and it
Yeah,
should be applied early, if we say, and that use of prone position early may get a patient out of the ventilator without the needing of ECMO. This is a trend.
exactly.
This is a trend which we are seeing. We don't have a study, but this is something which we are witnessing.
Exactly.
But
Exactly.
one thing for sure, that prone position needs to be started early. Now,
Uh,
PEEP came into the picture when this trial came, and there was different tables. This is a FiO2 table, this is a PEEP table. But the problem is clinicians or the healthcare professional intensivists always struggle with this PEEP optimization, PEEP titration. It feels that in spite of many protocols, in spite of many guidance, this is a never-ending debate or struggle sort of things. So, what's your say on this?
hmm. And so I think that there is one paper we recently published, a reanalysis of the lung safe, that clearly shows that PEEP at the population level has a U-shaped association with outcome. Okay, too low PEEP associated with bad outcome, too high PEEP associated with bad outcome. So, and I think this U-shaped relationship, it's not just valid at the population level, it's valid probably at single patient level. So that's why we with non-protective ventilation, it's easier. It's not necessarily the lower the better, but generally speaking, the lower we keep the driving pressure, the better. Okay. With PEEP, it's not exactly the same. We need to find the best balance between overdistension and collapse, and how to find it has been elusive so far. I personally liked the approach from the ART trial. So recruitment and a PEEP that would uh, lead to the best compliance. But unfortunately, and this is not a criticism to the colleagues, that's what it was. The way it was applied was very aggressive, and that probably led to the negative results we saw. So EIT is providing a lot of help in this, in that it's able to dissect the heterogeneity of the different lung regions. And I am quite optimistic that in the next 10 years, we won't have a protocol to set PEEP, because, as we say, it's very patient individual, but we will improve our understanding on the effects of PEEP, and so being able to optimize it in each patient.
So, correctly said, you said in the next 10 years, maybe we will not have a table or something to optimize PEEP sort of things. But in the next 10 years, I would say uh, there will be AI, which is coming as of now, and it is coming in the mechanical ventilation over the next 5-10 years. So, will we teach the future lectures or something we will teach to this AI sort of thing, or to machines, or we'll teach to the humans at that time? How means ventilator, will they be able to adjust automatically, or still we need to teach the humans or intensivists which are there?
Yeah, that's an excellent question, and of course AI is coming quickly, and myself I have also taken advantage of AI to, let's say, put down into words my into text the words I had recorded. So of course it's changing many aspects of our lives. The way I see it applied to mechanical ventilation is probably an earlier detection of given phenomena. For example, there are already ventilators that have AI algorithms to detect asynchronies, or, for example, detect overdistension, or detect flow limitation. And probably the ventilator could suggest clinicians, I would suggest to do this and to do that. But at the end of the day, at least for the next years, I think that finally the responsibility will still be in human hands. Okay, it's like some self-driving cars. They can drive themselves, but still you need a human that is sitting there and be able to intervene. The other point is in order to train properly the AI, I think we need to have a large data set, which is nowadays relatively easier to find, but we also need benchmarks. Okay, so for example, if I want to train my AI on asynchrony, I need to be able to have a human that it's teaching
Okay.
what these asynchronies are on the waveforms. So that's the other challenge, I would say, having proper gold standards for what we teach to the machines.
So means what you see is that AI will assist in picking up the
Yes,
problems early, and so that we can intervene more methodologically earlier in managing those patients. It will help as a more better tool, as a smart ventilator sort of things, rather
yes,
than as an isolated thing. So
that's the
right
idea.
now, but for as of now, what we could understand from you is keep the driving pressure low and keep a balance, optimal P, which is not too high and not too low sort of thing, and prone early.
Exactly,
That's
exactly,
something. Now,
exactly.
other than this ARDS and all this thing, there is one question which I personally wanted to ask, that intubation or intubating a patient is something very different if you are doing it in OT, and very different when you are doing in ICU or emergency sort of scenario where the patient is crashing technically. So in spite that we need to do it fast, we need to do rapid sequence, and we need to do that, which one principle you feel that it should never be compromised, even if for the sake of speed we should not compromise that thing in a crashing patient while intubating?
Sure. Yeah, I think on this we've been doing some work with my friend and colleague Vincenzo Russotto from Turin, Italy, and really he has been able to. We have been able to show how dramatic the moment of intubation can be for patients, not because of the difficult anatomic airway that's pretty much easy in many cases, but because of a difficult patient. And I think that a good level of a proper monitoring where everything is at place to monitor patient respiratory rate, heart rate, blood pressure, and as soon as the patient is intubated, end tidal CO2 should never be compromised for the speed. We saw that so many centers still did not have an ATCO2 verification of the proper endotracheal intubation, and that's something that really should absolutely be avoided. But sometimes, for the need of speed or for the lack of equipment, we make trade-offs. And to me, the presence of high quality monitoring should never be accepted as a trade-off. And the human factor, right? Of course, if we are able to have colleagues supporting us, if we are able to have the nursing prepared, just a little bit of moment of briefing so that everybody knows her or his tasks, that's the other aspect. So monitor with the machines, but also monitor the human factor would be my suggestion.
It's so encouraging. I could not say how much encouraging is this for ESBICM, which is the B stands for the Bedside, Educational Society of Bedside Intensive Care Medicine. And your words that you cannot rule out the human factor. Small debriefing, briefing about the intubation procedure at that moment, with who is going to do what we are going to do, good monitoring, and obviously an ETCO2 in place. But team working as a team at the bedside is a factor which cannot be compromised. So thank you for this beautiful words. And now, once we have taken on the ventilator, and now I see that many of the young intensivists or trainees or nurses who came to the ICU, and always a ventilator, they look at the ventilator screen, and they feel a little bit shy, a little bit intimidated with this ventilator. So, what would you say? What would you give your message or words to them who are seeing the ventilator for the first time, as words of encouragement, I would say?
Yeah. Yeah, no, I think it's an excellent question, and sometimes I tell a joke, which is partly a joke, and it is the fact that I like mechanical ventilation because I am a little bit I'm fundamentally lazy, and so with mechanical ventilation, you just need to know one equation, the equation of motion, and that's it. Okay, so first of all, don't be discouraged because there is one thing you have to learn: the equation of motion. Then you have to understand it and put it in the various concepts. And to me, the suggestion is to take the ventilator off a patient and see how it works and take the pieces of the equation of motion one by one. See what happens in the airway pressure when you change the flow. See what happens in the airway when you change the volume. What happens when you change the resistance, when you change the compliance. And so at first understand the equation of motion in the passive patient one pieces by one piece. And there are also excellent and free of charge simulators online where you can learn this. Then put yourself in a little bit more complex situation, which is pressure control ventilation. Pressure control ventilation, it's well, physiologically has some advantages, but long story short, it's a little bit more challenging to understand how resistance and compliance impact the flow during pressure control ventilation. And so you took one step further. And then on top of this, add the activity of the patient. And every time you see a waveform, try to interpret it in terms of equation of motion. So your waveform, your airway pressure waveform, always in any time should respond to this basic rule. That would be my personal suggestion.
Thank you, Giacomo. I'll tell you a little fact about ESBICM. We do a course which is called the MacVent course, and right now we have almost 300 people in that, and from people from 24 countries. And I'm very happy to see that equation of motion is getting so much importance by you. It again emphasizes that this is something you need to understand that, and everything plays around it. If you understand that and the ventilator graphics, that thing, ventilator becomes very easy. And I would say, as a sort of your friend or colleague in your ICU, ventilator becomes very easy sort of things. So I'm sure that if people can get benefited with this short 20-25 minutes of conversation, they will get immense value addition, immense benefit from your book, which is Respiratory Failure and Mechanical Ventilation. And as we talk on this day, I think in 5-7 days it is getting released.
That's
If
the
I'm,
hope.
yeah. So please share the link so that we can post in the comment in the description of this video, so that we can our viewers can go and whatever they pre-order or get notified about that book there. And to request one, if you can we can have a copy so that we can have some lectures from it
For sure.
online.
For sure. Just send me your postal address and I will mail you a copy, definitely.
And second, in our mechanical ventilation course, if we can have a guest lecture from you based on your book, that would be very nice for our audience
Yes.
and students. They
Yes.
would love to hear from you.
I
And
don't like invite myself, but I think that I came through your ICU channel, and I think it's really beautiful because it's really uh, as I like teaching at the bedside. It's always also in the ICU with the residents, but during the courses we always try to have some hands-on, which is not exactly at the bedside, of course, but still it's practical because at the end of the day, you can teach people, okay, you have to measure driving pressure. Fine, but I need to know which button on my own ventilator I need to push to be able and measure the driving pressure, right? So the concept of ESBICM, so bedside, it's really it's really a helpful one. And so if you feel like having me in one of your lectures, thank you very much. And when you have the book, perhaps you can pick the lecture you like the most, and I can do it for you.
Thank you, Professor Giacomo. And it was means I can continue this for a very long period of time, but because of the your busy schedule, we'll close it here. And those who are listening, they can always post their comments, questions in the comment section of this video. We'll post a link to the book in the what we'll call description of the video. And if we can share your email also in this if they want, so we'll
Yeah.
flash your email on the video, so that if somebody wants to connect with you in regarding to mechanical ventilation from across the world, they can just drop an email to you for that matter.
Yes. Be a little bit patient in that it might take a while to reply, but definitely, please.
So it was very nice talking to you, and thank you for joining us. Thank you.
You're
See you
welcome.
soon.
Thank you. See you soon. See you soon. Thank you.